This is part 2 of gallbladder diseases and related disorders by Dr. Hesham Akkad, Professor of General Surgery at Ain Shams Medical School. To remind you with the intended learning outcomes of this lecture, as we have said in part 1, empyema of the gallbladder is one of the serious complications of cholecystitis. So this gallbladder must either be removed or must be drained. One method of drainage of the gallbladder is doing a cholecystostomy. Cholecystostomy means the introduction of a tube inside the gallbladder lumen to drain its content outside the body. In severely ill patients in the ICU, for example, this could be done non-surgically through percutaneous puncture under local anesthesia. The needle passes under sonographic or CT guidance from the skin through the liver, then into the gallbladder through its bed. This tract is less likely to leak contents around the tube into the peritoneal cavity, and if the gallbladder is punctured directly. A guide wire is introduced through the needle and the needle withdrawn. The tube is then introduced over the guide wire and the wire withdrawn. Thick pus need wide bore tubes for drainage, which are inserted by open surgery. Open surgery could also be done under local anesthesia in extreme cases, but usually needs general anesthesia. It has the additional advantage of removal of stones from the cholecystostomy incision at the fundus of the gallbladder before the tube is inserted. Under normal conditions, cholecystitis in absence of gallbladder stones is rare. Acalculous cholecystitis is associated with some severe illness, usually in debilitated ICU patients, in patients suffering extensive burns after severe trauma and after some cardiac operations. The fact that the gallbladder is inflamed but with no stones does not mean that the condition is simple and could be treated conservatively. Cholecystectomy is needed, but because most of these patients will not tolerate major operation, percutaneous cholecystostomy is the treatment of choice. Polyps of the gallbladder may occur as separate entity or as part of cholecystitis glandularis proliferans. In this disease, there are also small adenomata in the thickened wall of the gallbladder with small diverticuli which might contain calculi. These diverticuli might form fistulae with adjacent organs. Gallbladder polyp discovered accidentally by ultrasound for symptoms suggestive of gallbladder disease must be managed by cholecystectomy. Alternatively, a policy of regular follow-up could be taken in comorbid or senile patients. Gallbladder adenocarcinoma is rare but bears poor prognosis. The etiology is not clear, but may be related to long-standing calcular gallbladder disease and so occurs more in the elderly. Sometimes there are no associated stones. Most of the tumors are inoperable by time of diagnosis. If accidentally discovered by histopathology of a gallbladder removed for stones, and the tumor was seen to reach the outer wall at the site of the gallbladder bed, a completion wedge resection of the liver at the bed of the gallbladder is indicated. Accidental gallbladder carcinoma is one justification for the need to send removed gallbladders for histopathology after cholecystectomy. Although very rare, the importance of porcelain gallbladder lies in the fact that it is strongly precancerous. Some even consider a porcelain gallbladder a sign of an already existing cancer. The gallbladder wall is calcified and is radio-opaque. Accidental discovery in a plain X-ray mandates immediate referral to a surgeon for cholecystectomy. Hartmann pouch is a pouch that forms by dilatation of the gallbladder wall at the neck of the gallbladder under the effect of stones pressing from inside. Meritzi syndrome is a syndrome in which a stone impacted in the pouch of Hartmann fistulizes into the common bile duct. The cystic duct becomes adherent by inflammation to the common bile duct, and the connection between the gallbladder and the common bile duct is the fistulous opening. The syndrome is a cause of conversion of laparoscopic cholecystectomy to open because there is no duct to apply clips on, and laparoscopic cholecystectomy will be attended with high risk of CBD injury. Stone passing into the common bile duct or pressing on it might cause jaundice. A stone fistulizing directly from the gallbladder into the duodenum is rare. If the stone is large, it might cause mechanical intestinal obstruction. Usually it lodges at the narrowest part at the terminal ileum. The condition historically bears the misnomer stone ileus, as actually the obstruction is mechanical and not ileus. Primary stone of CBD is a stone which formed inside the CBD, while a secondary stone is a stone which formed inside the gallbladder then passed to the CBD through the cystic duct or a fistula. If a stone in the CBD is diagnosed within 2 years of cholecystectomy, it is assumed that it was in the CBD at time of surgery, but was missed to preoperative diagnosis. CBD stones might be silent preoperatively because they are small and floating in the CBD rather than impacting at its lower end. So bilirubin and alkaline phosphatase were not elevated, and the intrahepatic ducts and the common bile duct were not dilated, and therefore there was no indication to further investigate for a CBD stone by MRCP or ERCP. One of the presentations of a stone in the CBD is obstructive jaundice. Obstructive type of jaundice is characterized by that the direct or conjugated bilirubin is the mainly elevated bilirubin. Alkaline phosphatase and the more specific gamma-glutamyl transferase are also elevated. When the cause of obstruction is calcular rather than malignant, total bilirubin usually does not exceed 15 mg per deciliter, and the level of bilirubin tends to fluctuate up and down as the stone lodges and dislodges. This is called the laboratory pattern. Clinically, the patient is jaundiced, passes dark urine resembling the color of tea. Ultrasonography usually demonstrates gallbladder stones if the gallbladder was not previously removed. Intrahepatic biliary radical dilatation and CBD over 8 mm in diameter are seen. Occasionally, the ultrasound might detect the stone itself in the common bile duct, but this is not essential for the diagnosis. Second step will be to do an ERCP for stone extraction. If the diagnosis of a stone as the cause of obstruction was still doubtful after ultrasonography, then MRCP is done prior to ERCP. Another presentation of a stone in CBD is cholangitis. Cholangitis is predisposed to by a foreign body in the CBD like the stone. This risk increases if infection was introduced by instrumentation like PTC or ERCP. Therefore, antibiotic is indicated before and after these procedures. Cholangitis presents itself with a triad called Charcot's triad, namely jaundice, pain, and fever with rigors. The treatment is urgent decompression of an obstructed CBD together with antibiotics. Decompression is achieved by ERCP sphincterotomy and insertion of a stent, or by PTC catheter to the outside, or operatively by cholecystomy, stone extraction, and T-tube insertion into the CBD. A CBD stone at the sphincter of Oddi causes severe colicky pain of the epigastrium, usually associated with dark urine. If a few hours, the jaundice might not be apparent clinically yet. Dark urine is an early indicator. Acute myocardial infarction must be considered and ECG done until the lab results become available and show the obstructive pattern of jaundice and normal cardiac enzymes. Unless the patient has underwent recent surgery on or adjacent to the biliary tract, malignancy is the second most likely cause to the obstructive type of jaundice after stones. Jaundice rapidly deepens, usually is painless at the beginning. Bilirubin shoots to over 25 mg per deciliter, and unless the CBD was instrumented, cholangitis is rare. Iatrogenic injuries may be detected at time of its occurrence or later. It may end by stricturing the common bile duct or a hepatic duct. Post-cholecystectomy jaundice is usually due to either a missed stone or CBD injury. Missed preoperative diagnosis of associated malignancy with gallstones must be considered in atypical presentations. ERCP is the procedure of choice as it is useful therapeutically in either conditions: stone extraction and dilatation and stenting of iatrogenic strictures. If the CBD is completely obstructed or divided, surgery is needed to anastomose the proximal hepatic duct stump to the jejunum, an operation known as hepaticojejunostomy. Primary sclerosing cholangitis is another disease than septic cholangitis, caused by foreign body-induced infection of bile. In sclerosing cholangitis, there are primary strictures of the biliary ducts, usually multiple, and is presumably of autoimmune etiology. It is common in the Far East. Like in cholangitis secondary to stones, there is jaundice, but imaging studies demonstrate the multiple stricturing and attenuated rather than dilated biliary ducts. Liver biopsy might be needed to verify the diagnosis, as the treatment is different from secondary cholangitis. Ascaris and some flukes may obstruct the common bile duct and cause jaundice. The condition is common in the Far East. Choledochal cyst, although congenital, yet may not cause symptoms except in adulthood. They cause jaundice, but are also the site of increased incidence of cholangiocarcinoma. This is the reason why surgical excision is the best treatment if possible. The common causes of malignant strictures are cancer head of pancreas, infiltrating the lower end of the common bile duct, carcinoma of the ampulla of Vater, called ampullary carcinoma, or carcinoma of the biliary tract above, called cholangiocarcinoma. Cholangiocarcinoma may be intrahepatic, but more commonly arises in the extrahepatic biliary ducts. One occurring at or around the confluence of the right and left hepatic ducts, it is termed Klatskin tumor. The biliary system from intrahepatic down to the level of obstruction dilates. MRCP plays an important role in identifying the level of obstruction and the length of stricture. CT and MRI are useful in detecting a mass, its invasion of adjacent structures, the presence of metastases usually to liver and draining lymph nodes. Unless curative surgery is planned, as is in few early cases, palliation of biliary obstruction is usually achieved through ERCP metallic stenting of distal lower tumors or stenting from above through PTC for tumors of common hepatic duct or more proximal. In selected cases, operative bypass surgery is done through a cholecystogegenostomy. These are just examples of the worms that can invade the common bile duct we have talked about. For the next 3 slides, you can test yourself, pause in between, and remember that we are going to discuss this in the face-to-face session. Thank you. هما مش 3 سلايدز، هما 4 لكن زي بعضه مش هتفرق كتير.